On behalf of United Cerebral Palsy and Gillette Children's, we are proud to welcome you all to our professional learning series this evening. A few housekeeping topics is number one, this meeting is being recorded. So please be aware of that. We will not be taking questions during Dr. Healy's presentation this evening, but if you would like to post your questions in the Q&A icon on the bottom of your Zoom toolbar, we will take the questions at the end. Let's see, and then one more thing, if everyone could please go and change their display name. In your Zoom account, you'll see three little dots on your profile. If you could please put your full first and last name, that way we can ensure that credits get mailed to you after today's presentation. So if everyone could please go ahead and do that, that would be great. Reminder, Q&A for all of the questions. The chat is disabled, so any comments could be put in the Q&A. And at this point, we are proud to welcome Dr. Michael Healy, who will be presenting on hip surveillance in children with cerebral palsy. Dr. Michael Healy is a pediatric orthopedic surgeon and chief medical director of orthopedics at Gillette Children's in St. Paul, Minnesota. He completed his training and fellowship at the University of Minnesota and Gillette, and is a current member of the American Academy of Orthopedic Surgeons, Pediatric Orthopedic Society of North America, and AACPDM, American Academy for Cerebral Palsy and Developmental Medicine. Please welcome Dr. Michael Healy.
Great. Thank you, Tara. Go ahead and do a screen share. Oh, wait, I can't do it while you're sharing. There we go. All right. So let's first thank you all for joining. I think this is really an important topic and one that's kind of near and dear to me as a pediatric orthopedist. Calling up an X-ray of a 4 or 5-year-old child with cerebral palsy and seeing a dislocated hip is it's a gut punch. And knowing that we have ways of watching for this and doing something about it is really important. So thank you all for joining. I'll try and tell you a little bit about what we do at Gillette and what's just some general guidelines for a hip surveillance program would be, and go from there. First off, I have no real disclosures. So today's goals. Give me 1 second here. I have to get my mouse back. Because the panel was right in the middle of the slides. So today's goals, as were published previously, after attending today's session, we hope that everyone watching will be able to describe why hip surveillance is important in children with cerebral palsy. We also want to understand the role of GMFCS level in a hip surveillance program, as well as state several goals of effective hip surveillance. So with that as our set of goals, let's move forward. So why is hip surveillance important? It's important because over 1/3 of the patients with cerebral palsy experience some level of hip displacement. And we'll talk about the ways to figure risk and to analyze the level of displacement. But it's a significant number of our patients who have that happen. The degree of displacement increases with the degree of involvement. We'll talk specifically about that as well. Hip subluxation and dislocation can ultimately lead to a painful hip, and that's really one of the big things we're trying to avoid. It can lead to difficulty with mobility. It can lead to seating trouble, and delayed intervention can lead to more complicated or less successful treatment options where moving out of the reconstructive or preventative realm at that point, and we're moving more into the salvage realm. And those surgeries are just not as satisfying for the patient in terms of the results on a long-term basis. So before we get too far down the road of what goes wrong, let's talk a little bit about how things are supposed to develop. So if you look in the upper left-hand corner of this diagram, that's an embryonic hip at 16 weeks of age. It has separated. It's all cartilaginous analog at that point, but it's mobile. It would function as a hip, and that leg could move. If we look at then how growth happens and how it's supposed to go, is interstitial growth happens from the physeal plate or the physis. Thank you, autocorrect. It goes through longitudinal growth through that, and the triradiate cartilage also grows and causes the acetabulum or the socket side of the ball and socket joint to grow deeper and accommodate the hip. So they grow together. It's a symbiotic relationship where the pressure back from the acetabulum then causes that capital femoral epiphysis to grow from a very small nubbin of bone, that ossific nucleus, and cause that to grow from the inside out, ultimately leading to what we hope is a well-developed hip that is a nice round ball and socket that have grown up together and work very well in that relationship. So what is hip displacement? Why are we worried about it? Well, it's a condition where that ball and socket don't maintain a proper relationship. It can be in an anterior or posterior direction, as is often the case anterior with more DDH, and posterior tends to be more the direction in a neuromuscular hip. It can also come out laterally or posterolaterally. In cerebral palsy is the most common. That can be due to either femoral dysplasia, acetabular dysplasia, or a combination of both as they grow and as we'll talk about a little bit, don't develop in the way that we would like for them to. So subluxation versus dislocation. So on the left-hand side of this diagram, we see a hip that is in a typical reduced relationship. As we move farther to the right, we see more and more displacement. So some subluxation in that second illustration, where you can see that there's a lot of edge loading, and eventually that can completely come out of the socket to either a low or, in the far right condition, a high dislocation. Often with this, and it's not reflected in this diagram, but what we'll see in further diagrams and some x-rays, is that acetabulum becomes dysplastic at the same time. It, because of that lateral edge loading, begins to slope upwards and just does not contain the hip in the way that it should. Why does this happen? Well, it happens largely around consistent abnormal pressures on the hip, and those are generated in several ways. Largely through muscle imbalance, but not exclusively. The iliopsoas and adductors are key in that. They just simply are bigger and more powerful than the abductor muscles on the outside of the hip, given their mechanical positioning. The abductors are very efficient in terms of maintaining their work, but if the hip is not in the right position, for example, internally or externally rotated, and there's too much femoral anteversion, those abductors can actually function less as abductors and more as hip extensors. So that whole muscle imbalance idea does come into play in the formation or the dysplastic nature of neuromuscular hips. It can also be attributed to some pelvic obliquity. That can put one hip in a position of instability or take some of the bony coverage away. Progressive scoliosis can lead to some of that pelvic obliquity, as can a leg length discrepancy, which can develop for several reasons. One of which is if the hip frankly becomes dislocated, that will lead to a leg length discrepancy, or some functional leg length discrepancies can happen around things like knee or hip flexion contractures. I think it's important to talk about the difference between neuromuscular and idiopathic hip dysplasia because they are different, and the management techniques are different. Developmental dysplasia of the hip is typically a hip that is somewhat abnormal at birth. Capsular laxity can allow some abnormal motion. The femoral head is often subluxated at birth or shortly thereafter. And there's often a low volume acetabulum. So you have some level of dysplasia right out of the gate or right from the get-go. And those are typically managed through screening. Where neuromuscular hip dysplasia has a more typically normal hip at birth. The displacement is progressive and it's over time due to some of those forces and skeletal development that we just discussed. The management for DDH is different than the management for neuromuscular hip dysplasia, as things like Pavlik harnesses don't typically do well because of the age that the dysplasia presents. We use screening for children with DDH. So that's basically checking once at birth with ultrasound, where neuromuscular hip dysplasia requires surveillance or continually and checking multiple times throughout growth and development. So very different in that way as well. Most of you are probably familiar with the GMFCS classification, but because it's so important to a hip surveillance program, we'll just briefly go through it here for those that aren't. It's a way of looking at the child's ability to initiate and perform gross motor function. And it's a great way of sharing information. If you're just talking and say, I'm referring to a 6-year-old male with spastic diplegic cerebral palsy who functions at a GMFCS level 2, I think a lot of us can get a mental picture of what that child looks like and what some of their functional abilities and what some of their needs are going to be. So it's really helpful in that way. GMFCS level 1 can basically do most of the things that their peers can. They have some decreased speed, a little bit of loss of coordination, but can typically run and jump, and they can get up and down stairs without using their hands. GMFCS level 2 is also independently ambulatory. Typically needs to use a railing to get up and down the stairs and has some trouble with uneven surfaces, but can minimally run and jump and would be having more of a challenge keeping up more directly with their peers. When we get to GMFCS level 3, typically some level of assistive device is needed. They may be able to get up and down stairs using a railing, but not always. They can probably propel a manual wheelchair, which will be very helpful for longer distances or on uneven surfaces that may be very challenging to them. When we get to a GMFCS level 4, we're into very severely limited walking ability, even with the use of assistive devices. They typically use a wheelchair most of the time, may certainly have the ability to maneuver a power wheelchair independently, and can usually perform or participate in a standing transfer, which is exceedingly important, especially as children turn into young adults and their body habitus changes and their caregivers just simply aren't able to lift them in the way that they were once able to. And then GMFCS level 5 basically has very limited ability to initiate any voluntary movement, is not able to ambulate or even stand independently, and are dependent on others for their care. They have trouble with head and trunk control, and are at the kind of the more severe end, obviously, of the GMFCS spectrum. So why do we care so much about GMFCS level? And it's going to be a recurring theme here. And we care so much because it is directly related to the level of or the frequency of hip displacement. As you can see, on the x-axis is GMFCS level. On the y-axis is the percentage of hip displacement that exceeds 30%. And we'll get into how that's measured in a little bit. But the take-home message is that a GMFCS level 1 patient has nearly a 0% chance that they will ultimately have some level of hip dislocation or subluxation. There's a linear relationship up from that GMFCS level of 0 to the GMFCS to the 90% likelihood that child with that's at functioning at a GMFCS level 5 will have. So in between are obviously the numbers that you can see here, but that linear relationship is very important as we put together a hip surveillance program, as well as a management program for those children. So why does it matter? Again, we get back to 30% of children with CP are at risk of developing hip dysplasia. It's a high number because 56% of them will go on to develop some level of pain as a result of that hip dysplasia or subluxation, however that is ultimately defined. Early detection has better options than late detection, which is basically limited to salvage options. So we want to understand the problem, identify it early, and get on with management. So the X-ray on the right is a 1 year, 3-month-old female who was part of a surveillance program. And I use her not as an example of what works in a hip surveillance program, but why it's important. As she went through the process, her parents were extremely reluctant to do anything invasive. That was largely because she wasn't having pain. She was doing relatively well. She's cognitively doing very well. And they weren't noticing a problem that they could put their finger on. So she came and was being kind of managed through some outside physicians and other people before she came to me. And you can see that right hip is starting to get into trouble here. As we move progressively on, that right hip continued to move out. Now the left one's getting into trouble. We continue to progress. So she's in the 4-year-old range now. She came to me at this point when she began to experience pain. And it took in the neighborhood of another couple of months to get her in to see me. And in the time between this X-ray and this X-ray, a lot had gone wrong. I think the die had been cast through the referral process, and the fact that now her parents were saying, "Okay, she's hurting. Let's do something." And now we're basically left in salvage mode. So there are not good options for her at this point. So as sort of a natural history of how things can happen and how quickly they can happen over the course of a couple of years to even near the end of this process, a few months. You can see that capsular erosion on the lateral side of the right hip. You can see that there's just a misshape in the roundness of the femoral head is gone. The acetabulum is also very dysplastic and getting in towards some level of the Gothic arch. And the left hip is dislocated, again, with associated acetabular dysplasia. So natural history, not good. So that's why I would so strongly advocate for a hip surveillance program. So I keep talking about a hip surveillance program. What is it? Well, if we ask the World Health Organization, surveillance is a systematic, ongoing collection, collation, and analysis of data and the timely dissemination of that information to those who need to know so that appropriate action can be taken. So I think as we pull out some of the keys in there, systematic, okay, we know that we have some evidence of how to watch for hip problems and their development. We know that if we do that early on, early intervention is possible. And we know that then if those who understand that can take appropriate action, that early action improves outcomes. So this too will be kind of a recurring theme about how do we go about putting together a hip surveillance program? How have those that have done so and done so successfully adhered to many of these principles? So I think this is a kind of a good guideline for how to put together a good surveillance program, in our case for hips, but also according to the WHO for whatever it is you are needing to keep track of, keep an eye on. Hip surveillance was really first described by Dr. Mercer Rang at Sick Kids in Toronto. He began kind of that program of saying, you know what, if we understand what's going on and we understand what's going on early, there are things we can do. That really grew and took root in Sweden in about 1994. They put together a national registry and were able to really start to track what changes under a hip surveillance program. The team in Australia put one together in 1997. Both of these were kind of revised in around 2014. But are examples of how a good hip surveillance program can really benefit children. We'll get into a little bit more of that later. It's also now present in British Columbia. Dr. Melporia's got a program going there that started circa 2016. I think the important message here is, if you look, these are all national programs. Sweden has actually grown that program out and involves several other neighboring Scandinavian countries, and several states in Australia have very formalized hip surveillance clinics, and they have the ability to do so because they have national health programs in the way that we don't in the US. We don't have even state-by-state guidelines. We often don't even have intra-hospital guidelines where everybody does the same thing. So I think that there's a lot of work to be done in this area, but that said, we have some guidelines. The AACPDM published that as a care pathway in 2017. It's available on their website under care pathways. It is comprehensive, and we'll go through that in a little more detail in just a few minutes. So as we noted, the importance, we don't want to have pain. We don't want to have our children who are at risk realize that risk, and we want to get on things early. How do we do that? We know that migration is progressive, and we know that early and aggressive adductor tone management can be very helpful. There are a few ways to do that. My colleagues in PM&R do a fair amount of management with Botox and phenol to the adductors. We don't think that an obturator neurectomy is indicated. That can often leave the abductors running unopposed and create other problems. We can also combine surgical lengthening of adductors with phenol neurolysis. All of these are very helpful. The paradoxical thing is what we've learned from Dr. Shore in Boston, that those children on the higher end of the GMFCS spectrum, those in the 4s and 5s, really need this type of management the most. But unfortunately, they are the ones who tend to not have the best outcomes in this and have recurrence, while those on the lower end, those in the GMFCS 2 and 3 range, respond very well to this type of management, but are the ones who are at lower risk and don't, the natural history would not take them into a dysplastic condition nearly as much as those on the higher end. We do have options with orthopedic surgery, as mentioned, for reconstructive options, and still not moving towards salvage yet, but we can do femoral varus derotation osteotomies. We can do pelvic osteotomies, and those are ways to just restore that more typical relationship between the femoral head and the acetabulum, or the ball part of the getting it back into the socket. So we have a more typically functioning ball and socket joint. So some of the principles that we want to identify and monitor very and early indicators of hip displacement are based on age. We want to look at GMFCS level. Again, don't mean to beat this home, but too much, but we will. Migration percentage, we'll talk a little bit about that. And then management of techniques that have been done to date. Have we exhausted, or are we feeling like some of those injections aren't working as well as maybe they once did? And it's time to try something else, or try a surgical approach in combination with them as examples. So we said we talk about goals of hip surveillance, and they're relatively straightforward, and I think they make a lot of sense. We're trying to maintain hips that are flexible. We want hips that are symmetric in their range of motion, both in internal and external rotation, as well as in flexion extension. We don't want to see windswept hips. Those go on to be problematic quite quickly. We want children to be pain-free. We want their hips to remain well reduced. We want them to have the ability to live life to their full capacity and not have pain interfering. In order to achieve these, we have to, going back again to WHO specific standards or direction, assess risk, understand the entire child, understand the threshold for treatment, and then act upon that, because early intervention leads to better outcomes. So starting with assess risk, we've talked about this. Know the GMFCS level, know the associated risks. How do we employ that then? So GMFCS level 1 and 2, if we look just across the x-axis as a need for increasing frequency of surveillance, GMFCS level 1s and 2s typically need less frequent monitoring, either by all of the methods that we do that, both radiographically and through physical exam. I'm going to throw one wild card in there, and that's the group 4 hemiplegic with the winter gauge type, group 4. That is a patient, obviously with hemiplegia, who tends to have an equinus contracture at the ankle, has a knee flexion contracture, and probably internal rotation of the knee and anterior thigh segment based on some internal rotation of the hip, and as well as some hip flexion contracture. So that patient, although not truly at a GMFCS level 3, shares that risk level. They're probably more of a GMFCS level 2 in theory or practically, but because of their designation in that winter gauge group 4, will need monitoring at about the same level as the GMFCS level 3. And then the 4s and 5s need even more frequent monitoring because they are at the highest risk. We also need to accurately assess a child's condition. Hard to do. Communication is often a very limiting factor on that child's ability to assess and communicate their perspective on their health-related quality of life. Most questionnaires are not designed for children with cerebral palsy. The change to that is now the CP Child that was developed by Dr. Narayan and team at Toronto Sick Kids and Bloorview. Dr. Failings was also involved with that, and as well as other people in the team. It's basically a way to use the caregiver as a proxy for the child and to assess their health index quality of life with disabilities. It's validated for use in children, not adults, but it covers these areas that are listed here. I won't go through and read them all to you, but it's a very good way to get a sense for this child's needs and also a baseline situation of how they're doing in terms of day-to-day management. Is there pain? Are there things like that that's going on that we need to pay attention to? So it's a good tool. It's a very good tool, and one that can be used as part of this understanding the entire child. We also use radiographic monitoring. We know that proper positioning is very important. Lousy X-rays don't help us a whole lot. Unfortunately, we all face not ideal X-rays, and we would like to really kind of drive home the fact that making decisions on a not ideal X-ray can be problematic. You want to make sure that the pelvis is horizontal. We want to make sure that the patellae are facing upwards. We want to make sure that the child is appropriately positioned so that their pelvis isn't tilted anteriorly and giving us too much of an inlet view. We want to put a bolster under their calves so that their pelvis becomes level and is flat and gives us a good image to work from. What do we do with this information? We look at Reimer's migration percentage. It is mathematically the percentage of the ball that's outside the edge of the socket. So it's a ratio, as you can see here, of that portion of, of the head that's outside the socket relative to the entirety of the femoral head. That percentage can change rapidly, as you saw in that previous example. So what's the threshold for treatment? Now that we know kind of what we're doing and we're taking X-rays and we're getting all of these things put together, we're looking at about 30%. That is kind of an agreed upon number across many orthopedists. It's the number the AAC-PDM uses. It's the number that's used in those other surveillance models that I've shown you. The Pediatric Orthopedic Society of North America recently had a Delphi group that I participated in around management of hips in children with cerebral palsy, same number, as just a very good guideline as to what's our threshold. We've been monitoring, we've been watching, we may be trying some adductor things up to this point. But now when do we need to get orthopedics involved? Because this is probably becoming, or not probably, this is becoming a surgical problem that needs discussion before it gets out of hand. So a migration percentage of 30% is definitely represents an increased risk for progressive displacement, and a quality X-ray is very important. This is a measure. Our PACS system has some nice tools in it to measure that. You can see the Reimer's migration index on the left hip is 28%, and that on the right hip is 61%. So two very different looks at what hip displacement can appear, or how hip displacement can appear, and what level of dysplasia, and then how to measure that. Not everybody has sophisticated tools built into their PACS system. It's nice to have and it's very handy, but if you don't, this is a free app that's available, and you can use this to basically point it at the screen on your of your AP pelvis, and it will calculate the migration percentage for you. It's developed by the team out in at the Northern California Shrine at UC Davis, and it's a good tool if you don't. It's a good tool in general, but it's specifically a good tool if you don't have the ability to do that quickly in a PACS system. The other thing we need to really concentrate on is physical exam. We want to monitor changes. Things that we're looking for are new onset or progressive changes in hip pain, for example, changes in hip range of motion, difficulty with ambulation, difficulty sitting, a windswept deformity, a developing leg length difference, adductor spasticity. All of these things tend to indicate that something is changing. And based on that change, we need to take action. So recommendations for surgery are based on GMFCS level, appropriate timing, and frequency of X-rays. I mentioned the AAC-PDM, and this is their care pathway. I don't expect you to look at it here and go, oh, I get it. But it's on their website, and I do encourage you to take a look at it. It is nice and a nice algorithmic approach to hip surveillance. It's based on GMFCS level. It talks about when or intervals for physical exam, talks about intervals for x-rays. It talks about how to evaluate when the time is to refer to orthopedics. Uh, so no matter whether you're whatever discipline you are in, it's an effective and helpful tool, and I encourage everybody to go have a look at it. It's the one that we've basically adopted at Gillette, and I know several programs that I have a lot of respect for have also adopted the AACPDM hip surveillance algorithm. So we talked a bit about how this got started and why we think it works. We can look to our friends in Sweden who's kind of started this ball rolling, where if you look before they started hip surveillance, the percentage of reconstructive and preventative surgeries were largely the same, and those salvage procedures were about in the neighborhood of a third to half of those. If we look then to surveillance after their first 10 years of, or excuse me, to results after their first 10 years of surveillance, we see that there were no salvage procedures done. They didn't need them because they had done more preventative and more reconstructive surgeries early on. When you go then to their second year of, or second 10 years of surveillance, you can see that the reconstructive efforts grew, their salvage procedures stayed at zero, and they still had a fair number of preventative surgeries. So it was very effective, especially given the goal that salvage procedures indicate that there was a pain, and B, no longer good reconstructive options that would put more typical anatomy back together in the hip. We take that then to Australia and look prior to their hip surveillance clinics. 96 and 97, they did a fair amount of salvage work as a percentage of their reconstructive work. If you start then to look across the years from the time they started that hip surveillance clinic, you'll see the number of salvage procedures go quickly to zero, and the number of preventative and reconstructive surgeries stay relatively consistent, and in fact become more preventative. So again, an indication that hip surveillance does have a meaningful impact. Even here in the US, without a more formalized program, we can say that some of these efforts do work well. This is a patient that was seen in one of our outstate areas and felt that the person seeing them felt that they needed some help, was referred relatively early on. He's about 4 years old here, and that left hip is, both are in trouble, that left in more so than the right. When we look a few months later, even by the time he got in to see me, that left hip was quite problematic and concerning. It was starting to become painful. So he underwent, the first thing we did was got him into a spasticity evaluation clinic, and he was felt that he would do well with an intrathecal baclofen pump, which he has. So that was placed, and very shortly thereafter, he underwent hip reconstructive surgery. So he had bilateral VDROs and a left pelvic osteotomy, and got him back those hips reasonably well reduced. I've continued to follow him and have known him for a long time. We continue to get outstate x-rays, so sometimes they're not quite as good as I'd like because they try and get him standing all of the time. So although he appears to be quite windswept here in a supine x-ray, which we don't have, or by his supine exam, he's not. But the point being, as a 13-and-a-half-year-old here, he's staying reduced. He's doing well. He's pain-free. He is ambulatory within the house on a minimal basis. He tall nails and crawls a lot, but he's a pain-free and relatively independent young man. I continue to see him, and this is his X-ray at nearly 17 years of age. So I think what we noticed early on as a 4-year-old and did some things about shortly thereafter has really held, and I think has been an example of success up until this young man being now a young adult. So changes in the patient's condition mean changes in surveillance. That is also a need. If you notice those changes, it may mean that you need to change the frequency. It may mean you need to move to different modalities, such as more advanced imaging. Musculoskeletal changes are noted, such as changes in tone, development of pain, range of motion, gait changes, decreased sitting tolerance, progressive scoliosis or pelvic obliquity, and difficulty with hygiene can really be clues to the need to change up the strategy a little bit, or it's time to act. So in summary, surveillance and monitoring of these high-risk patients is key and evidence-based. Early treatment is really necessary to allow us to have reconstructive options and really prevent the need for salvage procedures. The goal is to prevent pain, increase mobility, and improve quality of life. That bottom line is basically something that we all, I'm sure and know, strive to do on a daily basis as we interact with our patients. What can we do as healthcare providers? Well, one, thank you for listening tonight. I think that it's important to be able to put together and utilize an important hip surveillance program. We want early evaluation. We want an understanding of the risk factors and how to employ them. We want to carefully monitor for pain as it presents in different ways. We also want to really listen to parents and caregivers. Obviously, they know these children in a way that nobody else can. When mom says something's changed, I'm concerned about X, Y, or Z, listen, it's something probably has changed. And then refer to orthopedics in a timely manner. We want to be able to do things early on. Please, if you're a physiatrist, use all those tools available to you. And if those are no longer getting the job done, I think any of us would be more than happy to help. So thank you for listening, and I'll be happy to take any questions that you might have.
All right, thank you so much, Dr. Healy. That was excellent. It's such an important topic to the children that we serve that have cerebral palsy. So I am Valerie Pericini. I am the Vice President of Clinical Operations and Innovation at United Cerebral Palsy of Central Arizona. I'm super happy to be working with Gillette's tonight to bring this presentation to you. I'm also have another hat on my head, and that's the co-chair of the Research Council for United Cerebral Palsy's national office as well too. So this is just great stuff. I just want to remind you, because I do see that some people have not. If you joined us late and didn't get that request to be able to put your name in your display name, put your name in there. You can change it just by going up to the top of your box there where your name is, and be able to enter your full name. That just helps us to be able to track you so that we can get your CMEs to you with no problem whatsoever. So we have a lot of great questions that are already here. So I'm going to start with the first one. It looks like this is from Kylie. Asked, what do we know about the impact of bony hip surgery? So it looks like you're thinking about a 5-year-old on gross motor skills. So evidently there's been numerous children that they lose their floor-based sitting and movement skills. Okay, I know what they were talking about here. After surgery and due to reduced hip range of movement. So it's hard for parents to feel like the open quote preventative surgery has not cost their child some important functional independence. So what do you think, Dr. Healy?
Yeah, it's a good point. There is some loss, especially those children that are significantly anteverted, get stability through W sitting, and a lot of the ability to do that does go because it's just not as anatomically a comfortable position for them to be in. They probably may not have the level of external rotation needed either to tailor sit and gain some balance in that way. So a good point. At some point there, there is a trade-off also that pain down the road is not something you can unwind. That's toothpaste you're not getting back in the tube, however you want to look at it. Once that kind of threshold is crossed, it's very difficult. So that's where really shared decision making, honest conversation with parents about what skills will be lost or what skills will be deferred, probably is the better way to put it, and allow for a more typical hip development to happen so that there's not down the road pain and displacement in preteen and young adulthood.
I'm just gonna hook onto something you just said about shared decision making. What are some of the common questions that parents ask you when they're coming up on these decisions to, do surgery?
Good question. They, for one, understandably, are very concerned about pain and how we manage pain. Will this hurt? I think we have a very effective pain management protocol. I think a lot of hospitals do. And I think I hear from a lot of parents that was bad, but it was not nearly as bad as I thought it was going to be. Anytime you put your child through surgery, you are going to feel some level of angst and how do we manage this? And I think we have some good techniques, but that's kind of one of the main things that parents tend to ask is how are we going to take care of that? It really depends on to extend your question to function. It really depends where we're starting from, and what are the expectations moving forward? Can we make, or is the expectation that an ambulatory child will do so more easily if their lever arm dysfunction is managed, and it may take some really intensive rehab to get there. But those are children that you can say, I expect that they will actually exceed where they are now, rather than those who may be at a much higher GMFCS level, where the expectations will just be different, and know that there may be some setbacks that are going to take a longer time to overcome, if they are able to be overcome.
Okay, so I can't resist because there are other questions, but I do want to know, because I'm a therapist, what do you typically, once, there is surgery or there's intervention, what do you typically prescribe after that? Like, what does therapies look like?
Yeah, so we have it pretty well protocolized. I want to get these kids up and moving very soon. I want them out of their hospital bed on day 1, day 2 at the latest. I want them getting, early movement. I think helps with pain management, helps with their goals of moving forward. And I think it's just physiologically best for them to do that. So that's the first thing, is really early management of movement, be it nursing or therapy, to get them going. If they are ambulatory or at least weight bearing, I get them going as early as possible. As soon as we start to see some early healing, I let them get up, do some weight bearing, start to take some minimal number of steps, and then we progress that through either be the home or the classroom or whatever. It is appropriate to take that early number of steps in a protected environment, wheelchair for longer distances, things like that. But I really want to encourage range of motion. I don't want them to get stiff. I want them to be up and getting that muscle activation going early, things like that.
Okay. Okay, so I'll go back to the people's questions and I'll put mine aside. So hi, Rebecca. This is Rebecca Ravish. She said, curious if there are some statistics on prevalence of repeat hip surgery.
Yeah, it's again a good question. There aren't any that are terribly consistent. I think some things that are general guidelines are younger. The younger the child, the greater the likelihood that there will need to be repeat surgery. And I'm very honest with the families about that. That we want to wait as long as we can, but not to cross that line to where our options become limited. I functional level also plays into that as well.
Okay, a next one. This is from Beverly. She said, I thought that the Swedish hip surveillance program used conservative measures for prevention? Question mark. Big question mark.
Early on, they do preventative measures conservatively, but they do also do surgical measures preventatively and reconstructively, but not exclusively. At least that's my understanding of their program. And it has evolved over time, especially as they've learned more and more from their early beginnings to especially revisions around 2014.
Okay, so Sierra had my question too. I had this when you were talking, the CP child questionnaire. So I know it's was created at Sick Children's, but where can it be found? I mean, is it published? What is the?
It was published in DMCN, Developmental
Okay.
Medicine and Child Neurology, in 2006.
Okay. Okay. And is it available? I mean, you can find the journal article, but do we know, is it available otherwise? Do we know that?
I do not know the answer to that. I know we use it, but I do not know what any licensing arrangements or anything like that
Right.
are.
Okay, right. Yeah, you just know you use it.
Right. And
Okay.
it's very valuable.
Okay, excellent. Okay, so Cindy is asking, surgeons in Cleveland no longer are utilizing spica casts. Results have been great. What is your post-op protocol on FVDs? Oh,
Yeah.
sorry.
Really depends on age of the child. I do everything I can to avoid a spica cast. Part of that is an intraoperative decision around what kind of fixation I felt we've got, what's the bone quality, how protective do I need to be. That said, I can count on one hand probably the number of spica casts that have need to be put on post-operatively for management of hip dysplasia and neuromuscular hip dysplasia in the CP population. I do a couple of things. We tend to use bilateral short leg casts and put a bar between them. That bar is removable for some range of motion by the families, for getting a pair of sweatpants on and off, or whatever, some loose fitting clothing, and typically knee immobilizers. That immobilizes the hip reasonably well, but allows the child to sit up, sit back, lay back, have a change in position. And when it also, I think, helps with transfers when you're scooping up the kid, when, one of the parents can just pick up that kid and move them. The whole lower extremity set moves as a unit instead of trying to pull them into one side into an adducted position. So I think it's really helpful in that way. And it allows families to take a break. Like a spica cast, obviously you can't take a break. So this does allow for some of that early range of motion as well.
Okay, so Chandler is asking, is there a certain age or age range that has more successful recovery following an osteotomy or hip reduction surgery?
Ideally, and what I try to get in is that 8 to 11 or 12-year-old window. I think they do very well. Their pain management is remarkable, and their ability to work with that. They are still small enough that most of the time parents can, the transfers are relatively easy, or easier, in that parents can often pick them up and move them as needed. I think the rate of recurrence, anecdotally, is lower over that age threshold. especially if global tone management at some level is introduced. We feel that does help postoperatively, and it also helps postoperatively with spasms and managing those. So I think that's a nice window. They also haven't, quite honestly, developed that teen or teenager approach to physical therapy. They actually tend to, especially in the hands of a good therapist, do as they're asked to do, and their rehab goes better than I don't want to.
Right.
Which is understandable. I know that post-op rehab does hurt a bit.
Yeah.
And to get over that hump, the best way to do it is to do it.
Question, you use the word salvage mode or salvage surgery. Can you expand a little bit more on that?
Sure. So basically, whether or not there is a hip joint that can be put back together in a meaningful way, has there been too much deformity on one side or the other? Usually the femoral side. I think the acetabular side tends to be more constructive later in the process. But you saw that one hip that basically the femoral head was pointed. And that's just not going to do well getting put back into the socket at that age or that level of deformity. So salvage procedures are for those that we just can't put back in where they are. So they can be femoral head resections. They can be pelvic support osteotomies where the femur is put into a real valgus position to effectively get the lesser trochanter going into the acetabulum more so than the ball. There can be in older patients trochanteric sparing osteotomies. So there are a lot of ways to just basically get the femoral head out of there and not be that pain generator against the pelvis. That a reconstructive effort gets, where on the other hand, the reconstructive effort gets that hip joint back together and can help with function, seating balance, a lot of things.
Wow. Okay. Yeah. Okay. Another question is, as a person with CP in my late 60s, I had hip abductors cut at 11 years and a varus osteotomy at 13 years with plates, pins removed at 16. So hips have remained in a socket all these years, thanks to Shriners Hospital. Oh, that's awesome. I love it.
Shout out to Shriners.
Woo, there we go. Although one leg has become shorter, have we done any longer term following of patients for how well outcomes function over time? And so, for Mark, it's been 5 decades.
Mm-hmm. I don't know if anybody's looked at 5 decades of outcome. I know that especially around other programs, rhizotomies and some femoral derotation osteotomies, we've looked in the 10 to 20 year range and found that outcomes were good. Some lack of variation between those who did have osteotomies and those who didn't in a control group in terms of quality of life. But again, anecdotally, I do adult clinic as well, and those who have had previous surgery tend to do better as they come see me as adults in terms of hip pain and range of motion than those who haven't had surgery. Certainly not exclusive. There are certainly those hips that just did not survive despite our best efforts.
And then Rebecca did have a question. She asked if do you have post-op protocol for families?
I don't know exactly what that means, but what we try and do is prepare them as well as possible ahead of time.
Okay.
So that is starting months before surgery. So if the child is very involved or medically fragile, we get them into our prepare program, a subset of the complex care team. So they're seeing the pediatricians 3-ish months before we schedule surgery for them, just to make sure that they are as tuned up as they possibly can be from a medical standpoint, a nutritional standpoint, things like that. The parents are going through that and their education continues along those lines. We have a SEMLS class, a single event multi-level surgery class that's run by one of our therapists and a social worker. to kind of go over post-op expectations with families. They can do that tour virtually now. We started that obviously during COVID and have continued it because families tend to like that and find it effective. So I think and then my conversations with them, I try and, prepare them as much as I can for what I've seen post-operatively. So I think a lot of what maybe the answer to the question about what do we do for protocol afterwards is what we do for protocol before.
Oh, right. That's important, right? I mean, that's actually so much better, right?
Yeah, expectations are if you can reasonably, get those managed well and they match what actually happens, families tend to be happy and satisfied.
Yeah. Very last question is for children with unilateral CP, is the less affected side at risk at all? What does that look
From a
like?
hip perspective, much less so.
Okay.
I would never take it out of the equation. I typically would say in children with diplegia or quadriplegia, we tend to do both hips at the same time, even if one is worse than the other, because we're maybe in a reconstructive mode on one and a preventative mode on the other. But knowing that there's a really good chance we're going to be in a reconstructive mode ultimately, and just doing it at once is best. I don't think the same thing can be said for children with hemiplegia. I do think that some of the torsional things that can happen, especially around the tibia, do show up on the contralateral side and should not be ignored.
Okay. Interesting, right? Okay, well, wow, what a great presentation. This is really good information. It's so, it's so prevalent. I mean, so many of our kids, these are the struggles that our families and children, these are the struggles they have. So, okay, so I want to just remind everybody, thank you, Dr. Healy, thank you. And I wanted to remind everybody, we're happy to have you. I want to remind everybody, one more time, if you've not put your name on your screen, I'm not sure what to call it, but we're going to have trouble tracking you. So we need you to have your name in there so we can get your CMEs to you. Also, there's going to be a survey for this presentation, and we ask that you fill it out. It helps us to know if we're on track. So help us out there. Again, you're going to receive CMEs from this course. So there is a certificate, and that's your name. We need to be able to know you were here. So again, help us out there. Also, you will get a link for the recording of today's presentation. And then the other ones, other presentations that have through the professional learning series can also be found on www.ucp.org. Just click on the research tab and you'll find it all there. And then the upcoming presentation, November 14th, actually, I will be doing that with Kelly Moberg from Gillette Children. So once again, UCP of Central Arizona and Gillette's, we're happy to be able to partner again. The topic there is baby constraint-induced movement therapy. So we hope that you join us as well. So thank you, everyone. Have a good evening. We hope to see you back soon, and have a good day. Take care.